so much for having me and for that introduction, Donna. And so I was contemplating what might be of interest to this group, and so I've come up with the talk title, Beyond the Provision of Services, Overlooked Aspects of Water and Sanitation. And so it's some experiences from the field, and I'm going to talk about 3 different research projects that I've been involved in that I think kind of dive deeper into just simply WACh provision. So Donna kind of went through this already, but I call myself a water treatment engineer, and I've worked in many countries around the world, and I did my PhD at the University of Guelph in Canada, and then I was a WACh specialist with UNICEF. So first I wanted to ask you guys, what does WACh service provision mean to you? Like what do you guys know about WACh? And what do you think when you hear water, sanitation, hygiene? Boreholes, okay.
Latrines and soap.
Latrines and soap, okay. Education, yeah, like hygiene education. Have any of you been involved in WACh programs? I think Johnny has, but anybody else? No. Are you ever involved in like selection of water treatment or latrines or anything like that? No. Do you know like health clinics are a huge area of interest now in the WACh sector because of lack of water and sanitation? So I think some of the things I'm going to talk about hopefully be important when you go into the field as practitioners. So these are kind of these 3 areas I'm going to talk to you about today. So some overlooked aspects of WACh. One, I wanted to talk about understanding point of use water treatment, and I'm actually going to talk about my dissertation work from Cambodia. There's not a lot of work still being done in that area. It's really hard to get funded, so there's not that much new stuff coming out. The second one is sanitation and the Sustainable Development Goals. So right now, what data and knowledge is lacking, and the second one is what is needed but doesn't count, is what I'm calling it. So I'm going to walk you through all of these. So we're going to do the POU treatment first. So I looked at 2 different point-of-use water treatment technologies in Cambodia. So one is a ceramic water filter and one was a biosand filter. Has anyone seen these technologies before? Yeah. So when I went to do my dissertation, I guess in 2007, I went to Cambodia and started asking questions about these technologies. They had been widely implemented for over 7 years in country, but very little research had been done. So there was a couple randomized control trials to look at the health impact, but no water quality assessments, and nobody really looked at like how they were performing in the long term over time in terms of microbial reduction as well as chemical treatment of chemicals that can be found in the water. So I had 5 different research objectives, but I'm just going to talk about 3 of them. The first was to evaluate the treatment performance of both filters in terms of the microbiological and chemical quality of the treated water, determine whether the technologies were capable of meeting WHO guidelines for drinking water, and then try to provide recommendations in terms of which technology may be best suited for a particular water quality. Because what happens is an NGO typically will find out about one type of water treatment technology, and then they'll blindly implement it across all households. And in terms of like water treatment, one technology is not going to work in every type of context. So I'm going to go into that in my talk. So my methodology was I used a case study approach. It was my dissertation work. I had some research funding from the Canadian government, but not a huge grant to work from. The first phase was I did an initial survey of households in 2 communities. So one was a biosand community where a big implementation had happened, and the other was a ceramic filter community. And then from that, I selected 40 households to study more in depth over a 6-month period. So we did a longitudinal water quality survey. So it was back in 2008. I went door to door with my team of Cambodian students that were working with me at NGO to try and locate all of these filters. So we went to hundreds of homes over a month to kind of track them down. So for the ceramic filters, there was 5 villages, and we knew there were 74 that were out in the field somewhere, and they'd been implemented in May 2008, and we only found 65 of them. They're kept within the home, so if people weren't home, we couldn't maybe get in to ask if they had them. And then we collected water samples from 56 of them. So sometimes we maybe saw that they had a filter, but we couldn't get access, so we ended up only doing surveys and collecting data from 56. The biosand filters, there was 2 villages. There was 81. They'd been implemented anywhere from 2001 to 2007. We found them all, but a lot of them weren't being used, so we ended up just sampling 59. Some people were using them to store rice and do all sorts of things, but they weren't using them for what they were designed for. And then so at each visit, we administered a questionnaire, took influent samples and effluent water samples, and then we we did the following parameters. So total coliforms, E-Coli. Are you guys familiar with those measures? They're typical measures used in water quality assessments. They're indicators of microbial contamination, but they're bacteria. And then the rest are kind of other water quality parameters, which I won't go into too much detail right now. So the study sites were in Kandal province, and Phnom Penh, the capital, is here, so just kind of outside. And these are the two different communities. So the ceramic filter villages were there, and the biosand filter villages were there. And this is kind of some pictures so you can see what they looked like. So from this 56 and 59 households from phase 1, 40 were selected, and the selection criteria were willingness to participate, the water source they used, so whether they used a well, lake, or river, we wanted to include all of those sources, but we excluded homes that used rainwater exclusively because rainwater is of high quality and we didn't think you'd be providing much treatment. Whether or not they blended or used multiple sources of water, because it would be difficult to track the quality of water from the influent to effluent, we excluded anyone who used multiple sources. We also looked at an asset index where we tried to assess their ability to store rainwater in the long term. So if they had like a motorbike or a TV, people with higher levels of assets were not included in the study because we knew that they could store rainwater for long periods of time, and therefore they might not use these more contaminated sources of water. And then infrequent use, or it'd stop using the filter. So we did some observations. So if like the biosand filter was dry or the ceramic filter was dry and it seemed like it hadn't been used, we excluded those households from the study. So we had 40 households, 20 of each type of filter, and then we monitored over a 6-month period. And you might think 6 months is a short period of time, but it's when the dry season is. So it rains a long time in Cambodia. When there's rainwater, people will use that, but we wanted to capture worst case scenario, so only when they were using the poor quality water. And households were visited every 2 weeks to collect water samples, and we administered a short questionnaire. And so this is me explaining why to capture the dry season. So I'm going to go through some of the results. So 11 samples were collected from each household, and the water sources for the filters were as follows. So ceramic filters, some people were using a deep well, some relied on the Mekong River, some had different types of surface water, and then some did use some rainwater, despite our screening criteria. Biosand filters, there was deep well water and surface water. And then they were analyzed, the samples were analyzed for the same parameters I mentioned before. And stored water samples for the biosand filters were monitored for total coliforms and E-Coli. So if you remember the diagram at the beginning of the two technologies, the ceramic filter sits inside the storage container, whereas the biosand filter has a separate storage container. So we also collected samples from that storage container because that's what they're actually going to be consuming. So I'm going to go through some of the microbial water quality results. So this figure is showing E. coli levels for biosand filters that were fed well water. And I'm going to walk you through the figure. So the first bars are the influent concentrations, the second bars is the effluent, and the third bars are the stored water quality. And so I used WHO kind of guidelines for E. coli concentrations. So low risk is considered 10 colony forming units per 100 mils. Medium risk is 100 colony forming units per 100 mils, and then high risk is 1,000 colony forming units per 100 mils. And so what we found is that 8 of the 11 filters produced water in the low risk range for treated water, but then 4 out of 11 saw an increase from the influent to the effluent, so the water quality is actually getting worse coming out of the biosand filter. So this is an example of when we're doing harm than good. And then stored treated water in 9 of the 11 filters was worse quality than the treated water, showing that once it comes out, it might be clean, but depending on the vessel used for storage, that can be problematic. And then initially 8 filters produced treated water in the low risk range. However, only 2 of the 11 filters had stored treated water in this range at the end. So here, these are the only 2 that kind of fell in this low risk range. And then in addition, 6 of 11 filters provided treated stored water, which was worse quality than the original well water source in terms of microbiological water quality. So they were treating their water, but then if they had just taken the water straight from the well, in terms of microbial water quality, they would have been better off. So this is an example of when a technology is not really appropriate for a well water source that can be low in microbial contamination. So E. coli levels for biosand filters fed surface water, this is where you actually see a reduction in the concentration of organisms. So again, the 10, 100, and 1,000 risk ranges. None of the filters consistently provided water in the low risk range, but that's the influent concentrations were quite high. All of the treated water was better quality than the untreated water, so that's great. And then 7 of the 9 filters had an average increase from treated water to stored water. So we're still seeing that contamination happening from the treated up to the stored water. So this is, now we're moving on to the ceramic water filters. And so again, we have low, medium, high risk. And this is ceramic filters fed Mekong River water. And so 8 of the 10 filters produce water on average in the low risk range for E. coli. So we saw a higher reduction in these filters. And then 2 of the filters, C19 and C20, produce water in the high risk range and medium risk ranges respectively. And then what was interesting is this C19 reported cleaning their filter frequently. So they were always cleaning it, but they used to use these, they called them cremas. It was like a dirty cloth, and they would always show me, we'd ask them how they clean their filter, and like, oh, we used this, and we assumed that that was actually contaminating it. So we made cleaning recommendations to the NGO that people actually don't clean them frequently because they can actually contaminate them more. And then C20 frequently had a dirty storage container, so you could actually visibly see that it was dirty, which is why we think the concentrations were higher. For E. coli, for ceramic filters that were fed well, lake, and rainwater, so there was one household that managed to store rainwater, or a couple, I guess, that stored rainwater all the way through the dry season, despite what we thought they would be able to do, so we do have rainwater data. Only 1 of the 3 households using rainwater produced treated water in the low risk range. 1 of the 4 filters using lake water produced water in the low risk range. And then C11 and C12 had little reduction in E. coli, and filtered C10 saw an average increase in E. coli. And then contamination in the storage container through improper cleaning was likely to blame for poor treatment of the poor quality of the treated water. So I actually, when I lived in Cambodia, I used one of these ceramic filters, and when I got it, I cleaned the storage container, and then I never touched it again, because if you don't open and close it, you're not going to introduce any sort of contamination. And I think a lot of you have lived and worked in developing countries. Thinking about trying to dismantle something like this and clean it and keep it hygienic is pretty problematic, I think, in itself. So, oh wait. So I wanted to share the kind of just summary. Neither technology consistently provided water in this low risk range for E. coli. And then I did a probability of exceedance analysis. So the probability of exceeding this concentration of 0 to 10 colony forming units was 56 to 67% for the biosand filters and 3 to 40% for ceramic filters. And then what we did notice is that the ceramic filters provided safe stored treated water more consistently than the biosand filters, and that's basically inherent in the design of the technology. And I'm going to show you why safe storage is important, because these are some pictures of some of the storage containers that we saw. So this is a biosand filter storage container that people were then taking water for treatment. This is a bucket that they used to collect surface water to then pour in the filter, and then they collected the treated water that way. So that's why sometimes technology design is important. This is a filter, so actually this was a separate study. I actually inserted kind of fake bottoms into many ceramic filters to see what kind of biofilm growth would happen in them and look at people's cleaning practices. So that's what this picture is, and actually we found that the less frequently people cleaned, the better the biofilm was in terms of contamination. So one last thing, I'm not showing the data for it, but these point of use technologies were exceeding the WHO guideline for nitrite and the combined guideline for nitrite, which is important for bottle-fed infants. So particularly the biosand filters increased the concentrations through the filter, and they had a lot of bottle-fed infants in Cambodia. And so this is a concern because some of the households also used to boil the water after the filter so that they'd actually be concentrating the nitrate into higher concentrations. So this could be an issue for potentially blue baby syndrome. Yeah. So that's, this is my research team of students that I worked with, and then my advisors for my dissertation. Then I received funding from a variety of places in the Canadian government. So I'm going to move on to the next part of my overlooked aspects of WACh. So the next piece is sanitation, the SDGs. So what data and knowledge is lacking? And I'm going to talk about a project that I'm currently working on that's funded by the Bill and Melinda Gates Foundation, and it's led by a PI, Joan Rose from Michigan State University, and there's several academic institutions that are involved. And basically, I'm not sure if you guys have a background in this, but around 1 billion people defecate in the open, and 61% of the world's population lack what we call safely managed sanitation services, which, do you guys know what safely managed means in terms of the SDGs? You know? Do you want to share? Do you mind if I put you on the spot? Yeah, you're getting close. Like it's containment of the waste so that it's either treated or safely contained, not just being discharged to the environment. So the SDGs, we're trying to move up from just basic services to what we call safely managed, so actually treated wastewater or containment. So right now, approximately 85% of the world's wastewater is discharged without adequate treatment into, and that includes in like North America as well. And so lack of sanitary controls, population growth, and urbanization is obviously going to exacerbate the spread of infectious diseases caused by pathogens in sewage. So Dr. Joan Rose, who's the PI in this project, came up with the idea to redo an ancient textbook. So this textbook is from 1983, I think. It is like the Bible for wastewater treatment in terms of pathogen reduction in the environment, but it's clearly outdated. So she's been working for many years, I guess it's probably 5 years now, on this project called the Global Water Pathogen Project. And it's an initiative of, there's 254 authors from around the world that have contributed data and have written chapters for this book from 49 countries. And it's open access, available online. But in its current form, it's a very academic resource. So it's not accessible to practitioners in the field who need to make decisions about sanitation. So what we're trying to do is develop tools to apply this knowledge and that people can use them in the field. So one is, this is actually, we're now calling it the pathogen flow tool and the mapping tool. And I'm going to get to it in a minute what these actually are. But first of all, I want to explain why pathogen type is important. Are you guys familiar with all the different pathogen groups? And most people have infectious diseases. You guys have a bit of a background on pathogens and why they're important. So in terms of treatment,
I think there's a lot of people who do, but some people don't.
Some people who don't. Okay, this will hopefully get everyone in the same place. So there's like 4 major groups that we're concerned of in wastewater. So viruses, bacteria, protozoa, and helminths. And size is really important. So viruses are smaller than bacteria, which are smaller than protozoa, which are smaller than helminths. And so just to give you like a comparison, viruses are like the size of a grain of rice, if you're going to think of relative size. Bacteria would be the size of that laptop, protozoa would be the size of the room, and a helminth would be the size of the building. So if you think of like removal through a filter, that obviously matters in terms of size. So the removal or disinfection through treatment systems, so protozoa like Cryptosporidium are really, really resistant to chlorine, for example. So you can't treat every organism the same. It's also important for transport to the groundwater. So viruses, bacteria, and protozoa are likely to get to the groundwater, whereas helminths is pretty unlikely. Their persistence and survival in the environment and treatment system really varies by organism. So some are sensitive to sunlight, some are not. So you can't like group all of these organisms together. And so these traditional indicators that I showed you all that data on, E-Coli and Coliforms, is what we use to evaluate treatment performance. And we can't really rely on those because they belong only to the bacteria group and they don't behave like the other 3 groups. So right now in a lot of countries, even in North America, you'll look at a total coliform reduction or E. coli reduction through the treatment system, but no one's looking necessarily at viruses, which you may have a higher concentration in the influent and then they might not be removed the same way. So we think it's important that we actually consider all 4 of these groups when we look at wastewater treatment. Let's see. So the first tool that we're working on, I think we called it the pathogen flow tool, is a tool that it's going to be mostly geared towards engineers that will help predict a pathogen reduction through a treatment system given the design and the environment and the operational factors. So we already have kind of a mock-up of it and we've been piloting it in Uganda with the wastewater utility. And the idea is that you could choose on-site systems, so whether it's a septic tank or like pit latrine, or you can look at the kind of more centralized systems like conventional wastewater treatment. And the idea is that you can change the configuration of your plant design and then look at the pathogen reduction through the system and then provide recommendations for risk. And the way the user will use it is that they will define what risk threshold that they're willing to accept. So what % reduction of pathogens they think is realistic. So we're not going to set that. World Health Organization suggests at least 4 log reduction for wastewater, but in some countries maybe that's not realistic. So depending on who is the regulator, they'll say, well, maybe we can achieve 2 or 3 log reduction, and then based on that health target, they can then look at their sanitation system and say whether or not what % of their waste is safely or unsafely managed based on that threshold. So that's one of the tools that we've been developing. And the other one, which I particularly like, is this mapping tool. So there's a researcher in the Netherlands, Nika Hofstra, that's been working on this for many years, where she maps pathogens in the environment spatially. So she'll look at sanitation coverage, so how many people have access to latrines and different types of technologies, and then what pathogens are being excreted. So they look at for example, they've done it for rotavirus in Uganda right now, and they can incorporate vaccine rates into it. They can look at shedding rates of rotavirus, and then they assume what proportion actually gets into the surface waters, and then use hydrological models so they can look at the flow of water and then see where the pathogens are concentrating. So the idea is you could speak with a government official and say, so these red areas are the kind of the hot spots. This is where you've got the highest level of contamination of pathogens. Therefore, that's where you should prioritize your intervention for sanitation. And then you could look at different technologies, different configurations. So for example, they did something on sewerage systems. If you invest in sewering everybody, but you provide no wastewater treatment, it does absolutely nothing for the risk, and then it actually concentrates it in one area. So it's very powerful when people are like, oh, we need to have everyone on a sewer, but then they don't invest in the end infrastructure. That's problematic. So these are the tools that we have under development. We're 1 year into the project, and we have another 2 years to go, and we'll be moving to India to see how transferable the tools are from one to another. And my job is to work between the scientists and the practitioners and try and align everything. So I've got my work cut out for myself. So next step is we're finalizing and rolling out the tools in Uganda in September and moving to India in year 3. We want to start to incorporate animal feces also into the mapping tool, because that's another area that is largely neglected, but we're not quite there yet. And then actually we've just been invited actually to submit this Department of Defense proposal, and Donna's on the team, to look at antimicrobial resistance along the sanitation service chain. And we're also going to do a case control study of children in Uganda and Mozambique to look at environmental exposures and risk factors that can contribute to AMR infections. So moving on to my last area of overlooked aspects of WACh, I'm calling it what is needed but does not count. So this is a project that my PhD student's been working on, and it's funded through Grand Challenges Canada, and they get money through the Gates Foundation as well, and this organization called Aerosan that's based in Nepal. And so it's bacterial contamination on community and household latrine surfaces in Kathmandu, Nepal. The data I'm going to show you is from a very small pilot study, but we've just been granted funding to do a scale-up of it, so it's somewhat preliminary data. But right now for the SDGs, the goals for WACh include ending open defecation and then access to what we call basic services, and then progress towards that safely managed service. But if you look at the definition of basic, it's used of an improved facility that's not shared with other households. So community latrines or shared latrines, they don't count towards the goals right now. So they're excluded from basic sanitation definition due to concerns around accessibility, safety, gender equity, and cleanliness. And what we're interested in seeing, is it really true that they're not as clean as household latrines? Or if they are appropriately managed, can they be as safe as household latrines in terms of bacterial contamination? So some studies have identified health risks associated with use of shared sanitation facilities. There's really a lack of evidence that there's a significant difference in cleanliness and then health benefits between private and shared facilities. The data is pretty poor to date. And realistically, to meet the SDGs and provide sanitation, a lot of these urban environments, there's not enough space for people to have their own latrine. So community sanitation needs to be considered, and we need to kind of move forward with that. And so our study site was in Kathmandu, Nepal. Nepal is rapidly urbanizing. They're expecting the population to double in the next 50 years. There's a huge shortage of sanitation facilities because of urbanization and then the earthquake and the lack of financial resources. So the government's actually installing a lot of these community latrines now, and our partner's been working with them on that. So here's just some headlines. 43% of Nepal's urban population lacks access to a toilet, report says. Here's another one, 2.6 million Nepalis still lack toilets, so there's clearly a need. So the latrine technology that Aerosan's been doing is a community sex-segregated latrines with urinals for men. It is pay per use, and it's run by private operators, but the technology is anaerobic digestion, where they can generate fuel, so they actually operate a tea shop and then generate income that way, which then subsidizes the pay per use, so it's affordable. And right now, the cleaning practices on the slab, they've been using just water only, and then other services, they were using soap and water. The reason they only used water on the slab when we came was because they were worried about affecting the biological process of the anaerobic digestion, because if you put chemicals down, then it will affect the biology, and then you won't get the same output of fuel. So the purpose was really to quantify and compare the bacterial contamination on latrine surfaces on two types of community latrines and household latrines in Kathmandu. And we want to identify what surfaces might be more likely to contribute to disease transmission. So Shannon went last year, and she was there for maybe 10 days. It was really short. It was on a shoestring budget. I think it was $6,000 was our budget, including the plane ticket. So this is the data set isn't extensive, but so she swabbed 2 community toilet sites, and she swabbed them during dirty and clean conditions. So at the very end of the day, before they were cleaned, she would swab them, and then she swabbed them first thing in the morning before anyone used them after they had been cleaned. And then she did 5 household sites in Kathmandu that were chosen at random, some Western-style toilets, 2 pit latrines, and they were just swabbed once at midday, and we were asked not to clean because we didn't want to bias people's cleaning abilities. We just kind of wanted to get status quo. What are they like when you go into a household latrine? And then we did some control sites at Temple University because we assume our community sanitation is appropriate, right? We accept that, so we thought, well, let's take a look in our clean and dirty conditions at Temple. And yeah, our library site was selected because of the highest traffic. So the surfaces swabbed, this is kind of the code. TS is the toilet seat or the slab. AC is the spray handle or bucket that's used for anal cleansing. DH is the door handle. W is the wall and the pit latrines. SH is sink handle at the hand washing station. F if it was the flush for the flush toilet. And then we did some floor samples in the United States because we weren't really recovering anything from the toilet seats, and we weren't sure if it was our methods or if they were really clean. And then we did do a couple money samples just out of curiosity. So the methods, we use a method by a microbiologist, Chuck Gerba, who's in Arizona, and he does swabbing studies of like bathrooms. And you ever hear the stories in the news of like people swabbing lingerie and bathing suits and stuff? It's this guy. And he's done a similar study. I think he did some latrine study in Cambodia and compared also, I think, to the US. So we followed his methods. So we had these swabs that were in a certain solution, and then the swabs were vortex, and then we analyzed for total coliforms and E-Coli using membrane filtration, and we processed them in a local lab in Kathmandu. So Shannon did all the processing. So the results, we ended up having 96 swabs taken from the community toilet sites and 23 from the household sites, and then 24 were taken from Temple University sites. And then almost all samples collected at Temple recovered no bacterial contamination except for the floor sample, so everyone was pretty happy about that. So some of the results, these are the bacterial concentrations for the community latrines under dirty conditions. So the left is total coliforms, and then the right is E-Coli. And you can see really that can you see this? I don't think so. So it's showing up. The toilet seat was the most contaminated, or slab, which isn't surprising. And then the anal cleansing bucket, and then the door handles were actually pretty contaminated. The walls not so much, but then the sink handles also for the toilet, or sorry, for the hand washing station. But then if we look under, it seems to have stopped working. Is there a click? another? The mouse? That'll work. This will work? Yeah. So then you can see the concentrations under clean conditions. So after they were cleaned at the end of the day, and we didn't alter their cleaning, we just went to see what they're doing. Even just using water on the toilet slab, they reduced the concentrations of bacteria significantly. And then comparing with household latrines. So this is just the status quo when we went to the household latrines. You can see there's some contamination, but they weren't as good as the clean. They were kind of in between the two, the dirty and clean situation. So some of the results, we did some statistical analyses, and let me see which one this one is. So comparing community latrines between clean and dirty conditions, there was a significant difference in the toilet seat, the anal cleansing bucket, and the wall. So we did see a reduction based on their cleaning between the two situations. And then for community latrines under dirty conditions compared to household, actually the only difference was in terms of the toilet seat. So really, and that was under dirty conditions. And then if we look under clean conditions, there was actually no difference between the community latrines and the household latrines, kind of suggesting that if they are cleaned and maintained regularly, and that's kind of a big if too, that they can be as like sanitary as a household latrine that is now counted towards the SDG. Now we have a small data set and there's clearly limitations, but we're going to go back and do a more rigorous study and also look at frequency if they were to clean at different times of the day. At what point, like after high traffic, should they start cleaning to make sure that they stay not dirty? Because we don't know if at like 10 in the morning they're dirty and then they're dirty like that for the rest of the day, therefore kind of higher risk exposures. So conclusions were in the community latrines, the most contaminated surfaces were the toilet seat and latrine slab, tap handle bucket used for anal cleansing, and door handles. And then the household latrines, the same areas, and also the flush handles. And then we also found almost no difference in bacterial contamination between the household and community latrines. And then a significant difference was found between the toilet seats and the latrine slabs from the dirty community latrines and the household latrines. And then, but like I said, that relationship didn't exist when you compared clean toilets. So we're suggesting that shared community sanitations may not be less clean than household facilities. And we've identified which surfaces are important for cleaning, and so we're going to be developing a cleaning protocol for the organization to use. And we think more frequent cleaning during the day could increase the cleanliness of the latrines. So I think this might be my last slide. So beyond technology service provision, in terms of WACh, what I think is really important for you guys to know, provision of technology is not enough. And then appropriate technology selection for context is really important. So thinking about those point of use technologies, don't blindly implement, like take some time to think about what technology might make sense depending on the water quality and context. Science can be used to inform decision making, but there's a lot of translation that's needed, and that takes a lot of time. I think we have a lot of scientific information, and you guys are in an area where you can understand it, but there's not a lot of work being done for translation, and it's hard to get it funded. And I've kind of placed myself in between science and practice, and I think we need more and more people doing that. And I know Johnny comes from an institute where that's their whole goal in the WACh sector, is to really move the needle from science to practice. I think there's a disconnect from reality and what's practical in the SDGs, and I think sometimes people deciding on the SDGs aren't always the practitioners in the field, so I think it's important to advocate for what is also realistic. I recognize all the indicators, people battle over each single indicator and how difficult that is, but if we can move the needle towards something more realistic, I think that's important. One thing I noticed when I was in the field, we used to do a lot of community-led total sanitation, and people would be building pit latrines in the middle of nowhere, and none of those latrines counted because they didn't have a concrete slab. But you're not going to put a concrete slab in a village that takes 2 hours in a boat that's this big to get out to. Like, it's just not reliable. So yes, the waste is safely contained, but how do we get those initiatives like counted towards the goals? And because it changes the agenda, because then implementers are forced to then put in these mechanisms that maybe make no sense at all. So people are going to push towards individual latrines when really a community latrine with more safely managed waste is probably better for the environment than someone having their own household latrine and them dumping it out into the local waterway. So these are just things I want you guys to think about. And then the last one is this no one-size-fits-all solution to meet the SDGs, which I think is true for every SDG and a lot of things in development, but people sometimes want that silver bullet, and it's just, I know it makes it harder, but it just doesn't exist. Yeah. And I think, yeah, those are all my slides. I wanted to leave lots of time for, I think, questions. Yeah, we have 20 minutes? Yeah. I'll take questions about my talk or working with UNICEF or anything. You guys can ask me any questions at all.